Our next presentation will be by Dr. Riccardo Ammannato. He graduated from Genoa University in Italy. He specialized in restorative and aesthetic dentistry. He has developed and published in 2015 and 2018 on the International Journal of Dentistry, IJED, the new and no prep approach to restore worn dentition, the indexed technique. He is the author of articles on adhesive and restorative dentistry and speaker in international courses and congresses. Without further ado, I would like to invite Dr. Riccardo Ammannato to make his presentation.
Hello, can you see me?
Yes. Your presentation,
we cannot see you, but we can hear you.
Okay, yeah. Coming. Sorry. Okay, here we go. Can you see me?
Yes, we can.
Yes.
Okay, wait a sec. Yeah. Can you see my presentation?
Partially.
Okay. You see it now?
No,
No.
not the whole presentation. Just okay. Yes, now we can see it.
Good.
You see it now?
Yes,
Yes.
we can see it.
Okay, so it's full screen now.
No, it's with all the slides, like in the editing mode.
Okay. Wait a sec. Because I have a problem here. Wait a sec. No. You see it?
Yes, but it's not full screen.
Not full screen.
Mihai, do you have an idea how to help?
If I can see the screen again, I can look it up to see the button for it.
No. Condividi. Oh. Why don't you see the presentation?
This is the entire screen, I think. You could share the entire screen and then open the PowerPoint, and
Yes,
we could see the PowerPoint.
Yeah, but in fact, I have the entire screen here, and I'm sharing. Now it's shared.
Okay, yeah, we can see it.
and now switch the active screen to the presentation. You won't be able to see the screen anymore, but it's not a problem. We can still see you.
Well, but where is the full presentation?
Are you using two screens?
No.
You're going to have to open the presentation again. Go to the desktop and open the presentation again.
Yeah, wait a sec. Wait a sec. So this is presentation. Now my presentation is here. I open it, but I don't, okay, no, I can't. I need to go present. This, it's telling me, go to full screen. I click full screen, and I'm sharing.
Yes, and now you need to go to the presentation on this screen. Go to the presentation.
Here we go.
Yes, it's perfect.
Okay, it's perfect. Yes.
Okay, perfect. Sorry for the delay again. Thank you very much to all the team that organized this fantastic event, which is today is very complicated to manage to organize something that is online, especially like these technical problems, and obviously something that is in person. And so really thank you for your effort, and thanks for having me here, which is a really great pleasure to all of you. And I'm the last one of the day, so I will try to speed up, because probably all of you are very, very tired and exhausted with seeing teeth and all the presentation through the day. So we'll try to focus, and I want to give my let's say my point of view managing today worn dentition through my approach that I developed with the index technique, which is a direct and indirect approach. So it's a hybrid approach, and we will see this later on. Okay, and can you hear my voice? Everything is clear, right?
Yes, it's perfect.
Okay, thanks. Okay, so the menu of this lecture is the evaluation before, as first step, is what we want to evaluate before going to doing the rehabs. Okay, we also see the previous lecture where I really totally agree with them that we need to focus before going to restorative, whichever treatment we're going to do, whether it's going to be composite, ceramic, zirconia, or whatever, but we need to focus on the etiology, especially when we are managing tooth wear, which is quite a complicated topic. And so very briefly here, but I just wanted to highlight that the etiology, it's very, very important to detect here. And we have physical causes with friction, and we know what is friction. So it's loss of tooth against another tooth. Then we have abrasion, that is a friction between the tooth against an exogenous agent. And then we have the chemical causes, where we have corrosion, corrosion is today really increasing a lot. And so it's something we need to focus a lot. And all these the physical causes, chemical causes, are very often merged together. It's a cofactorial problem. Maybe in some cases we have a higher percentage of a physical cause, and in others we will have something that is more on the chemical side, but very often they are together. That's why it's not so easy to detect which is the real cause of this tooth wear that specific patient has. However, what we need to do, it's a very deep data collection and data processing. In our data collection, we need to, as we see here, we need to catch all our photos. We need to also gather all the x-rays, different kind of x-rays, depending on our findings. We need to gather also our, or through an analog workflow, our models, our initial scans, the periostatus. We need also to do something very important, which I do in my protocol in all these cases, the checking the muscles and the checking the TMJ, checking the fan, all that kind of stuff are very, very important to integrate in the teeth. We have a system that is around our dentition that must be also taken into consideration, especially in this kind of cases. So when we gather all the data, we need to then to do our data processing, okay? And in the data processing, we do what we usually do in prosto cases. What we're going to do, we're going to do our project, where very often in open vertical dimension of occlusion, and then we will do our test drive. So we want to transfer our WhatsApp, our project that was based on an aesthetic and functional analysis, open the vertical dimension of occlusion, either in CR position or neuromuscular position, depending on our findings. So it's not all the cases in CR, or not all the cases in neuromuscular position, but depending on the situation of that specific case. And then we want to do the test drive with the provisional, because we want to test the aesthetic, phonetic, function, open of the vertical, the new static, and the new dynamic. Okay, so all this stuff is very important. Then we can go to our, let's say, definitive restoration in whichever material we want to deliver to that specific patient. So this part, we're not going to stick you to time, but is the most important part, the etiology, what is behind the etiology. And so now let's focus on my second step that I want to share with you, which is this molding approach, the Indirect technique, the advantages of this kind of technique, of this molding technique. Again, the Index technique, you can have here my articles. We're going to share also at the end my website. I also have my online courses also there. And however, the Index technique is a molding approach that is useful to restore one or more worn teeth, especially to restore full arches. Since this molding approach is a direct molding approach, so the material that we usually use is composite, okay? And through this direct copy-paste approach, in fact, we have a WhatsApp that is delivered by the technician based on an aesthetic and functional analysis on the all the etiology and all the findings that we did in the beginning. And we have, so through a transparent silicone index that is built on this WhatsApp, which is the guide to do this copy-paste, so this composite molding. And this technique can be delivered on anterior and on posterior dentition, okay? And it's a no-prep approach. So I have a hot question that I would like to share with you. So which are pros and cons of a single molding like the Index technique and a full molding like, for example, the flow injection, which is very also there, it's a hot topic and it's very fancy today. So here, just in a few slides, I wanted just to highlight the advantages of a single molding, which is the only single molding technique that we have in the literature today. All the others are, like the flow injection, are full moldings, okay? So the single molding, since I want to do, I do my copy-paste approach, my molding approach with a single molding, the single index, the single key has a problem. It's the stabilization, because since it's single, it's not so stable, and I totally agree with that. Because of that, we need to stabilize our index. How we can achieve this? Through placing the stabilizers with the flow line stop references. So placing on the buccal side and on eventually also on the lingual or the palatal side, a stabilizer, which is the flow line stop reference. With some flow, you see the index here on a model, we place our flow, we cure it, and then after that, we just check again our index if it's kissing correctly our stabilizer, so our flow line stop reference, and you see it also here. So the stabilizer is, it leads to two advantages. One is a physical stop, because while I'm molding, while I'm landing on the tooth to do my molding, I have a physical stop that will stop my index, so will stabilize my index, my single index. And the other advantage is a visual advantage, because while the clinician is molding, I can see that I've reached the correct position, because the index is kissing the flow line stop reference. So again, if we compare also with this boat that is flying on the water, also this boat has stabilizers, okay, which are called foils in the specific boats. And if this boat wouldn't have the stabilizers, these foils, it would capsize, it wouldn't be stable running on the water. The same for our index, okay? And you can see here that we have the double ones. For example, we can place only one on one side, but it's even better to place it also on the lingual or on the palatal side. And here I'm just sharing a short video. I hope you can see it. Just let me have a feedback if it's not running smooth. And you can see it here. I have my stabilizer, the index is kissing my flow line, and I have also my matrices already in place. You can see my metal matrices. We can place also some Teflon tape. We will see something later on. And here is the composite. I use the packable composite to do this kind of approach, and I heat it up in special heaters, and then I will load it on the tooth. So we'll layer it on the tooth. I will spread it on the warm surface, occlusal surface. Then I will close again back after, obviously, I've done the adhesion. I will close back then my matrices after have squeezed down my composite in order to avoid bubbles. And now I'm landing with my index on top of my tooth, okay? And I will check through my stabilizers that I've landed correctly in the correct position in order to have a good copy paste of the wax up that the technician performed. And you see here that I have also just lighting. So you can see here that I'm removing the excess before curing, and since it's a single index, it's easy to remove the interproximal excess composite that will flow out. If I have a full one, it's much more complicated to manage this. That's why I prefer to use a single one after we have done the stabilization. Okay, so these are the two big advantages. I will have a better control of the removal of the excess, the interproximal excess of the composite. And here we're curing through the index, and we'll see later on clinical cases. And you see here that it's precisely landed there. It's kissing, the key is kissing the flow line, stop reference. So now I'm going to remove my key that you see there. And after removing my key, I will do my finishing procedure. But what I wanted to share with you is the fact that really we have minimal excess material here. I have a little bit more. I could have removed this before curing, but this with the scaler is just I'm going to break it with the scaler. I'm going to open up the matrices that were hugging up my tooth while molding, and here you see you just break it, and it's really minimal, the interproximal finishing that I need to perform. And this was the project, and this is the copy paste. And again, what I want to highlight, due to the fact that we have a single index, the interproximal management of the finishing is fast, easy, and predictable. So let's go to the next chapter, the molding techniques in comparison. So I just want to share with you, because also I do some cases with the flow injection, like in this case, to close the diastemas. So this case is outside of the wall dentition situation, okay? But it's just to share with you the differences between a flow injection and my single index technique that I've just shown you here. So this case. I need to close these diastemas. This was the desire of that very, very young patient, 20 years old. So we did all the project through the digital workflow. So here we have the technician. So he added the digital wax up, and you can see now here in a while, this is the digital wax up. I'm just going to go forward here. And also he delivered, we went through with the indexes we are doing in the last 2 years. Also, we are using, and we'll see later on also this, we are using 3D printed indexes. Conventional ones, like in this case, we use both the silicone ones plus the 3D printed ones. Okay, here I'm doing the check of this interproximal on the upper canine. Obviously, it's all no prep. We need only to close the diastema, so we are adding some composite. We could go also through veneers, ceramic veneers, but this was a patient very young. We wanted to manage this in a more conservative way, and tomorrow we could have the chance to manage this with a more indirect restoration. So since it's all no prep, we need to do our sandblasting on the enamel surface that we have. We are going to transfer, and we don't have the time here to share this with you, but we are transferring from the STL files and from the models, the 3D printed models, we are transferring the flow lines in the exact position that the technician placed them on the STL files and then on the models, also on the patient's mouth. Okay, so you see here I have my flow lines. So I will stabilize if and when I'm using my single indexes. And you see here I'm doing the try-in of this 3D printed key, and I'm checking that the index is kissing my stabilizer. Here I'm playing with also just to share with you guys different options. So this distal part of the number 11, I will do it with this index, okay? And here I'm doing the adhesion protocol. Now, and I'm using a packable composite, heated up packable composite. So it's a variation, let's say, of the flow injection. When I don't drill the holes, and I don't use, at least I use also in these kind of cases, I use also the flowables one, but without drilling, I just place it on the tooth, and then I will land with the index, because in my hands, I have less bubbles. However, so this is the curing of the bonding. This is, I'm placing the material, the heated up packable composite. I'm landing with the index, and then I'm going to do curing with 2 curing lights, one from the buccal, one from the palatal, and then I'm going to do my finishing. Now I just want to compare with you guys and share this with you. And I'm going to use now this kind of index, the 3D printed on the mesial side, as you see, of the canine. Here I'm doing the adhesion, and then I'm protecting the other tooth with some Teflon. I'm curing the bonding, and here I'm placing, instead of a packable composite, as you see here, I'm placing the flowable, okay? I fill the flowable composite on the tooth. I'm not going through the index, so I do this variation of the flow injection, and so I place it on the tooth, because for me, I reach less bubbles I have. And then so I land with my 3D printed index, and you see here in this first image, I have some excess there. So since it's a single one, before curing, I can achieve with a scaler, with a probe, with whatever you want, to remove this excess material. If I have a full one, it's much more difficult to go and remove this excess in this area. Okay, so here I'm removing, and then I will cure. And this is the situation. So it's quite clean. The shaping, the finishing interproximal, it's quite easy. Now here, I'm doing, again with the flowable, the mesiodistal of the lateral. We have our stabilizers here still, and then I'm going to use here, I'm placing the flowable material, you see it here, mesial and distal, and I'm landing with the full index, not a single one, then I'm curing, and this is what I achieve. I achieve a good result, however, the shape is correct, but as you see here, my finishing procedure here are going to be much more longer, not so predictable, and not so easy to manage, because I cannot remove, like on the canine, that which I have, where I had a single one, I cannot remove the excess. Or I can, yes, I can, but in a much more longer procedure, and not as predictable as I would like to do. And so you see here the situation before and the situation after. So again, we have here the canine, the mesiodistal on the lateral, and the distal side on the central. But this was just to share with you the differences between a full molding and a single molding, and we went through all the stuff. So now I'm just sharing with you another issue and another potential, let's say, dilemma that we have as restorative dentists, how we restore this kind of full rehabs. Now, we saw also a few presentations earlier in the day. Now we use composite. Do we use glass ceramic? Do we use zirconia? Do we use PFM? My answer to all this is what you're going to see here. I use a hybrid approach. So I use different materials in the same rehab. Okay, so I don't use all composite, or I don't use all ceramic or all zirconia, but I mix, and we will see just in a while. So my other hot question again, so is which restorative material we can use, as I just mentioned, when we use, if we want to manage our rehabilitation also with composite. And so when we use the single moldings, because I use the index technique, and when we use instead ceramic onlays or ceramic crowns or zirconia. However, when we use direct molding or indirect restorations. So I'm sharing with you this case. So I will share two cases. The first case, this one is a full analog case, okay, from A to Z, while instead the next one is going to be a full digital case. So why hybrid approach? Now we will reach this aspect, is because I try to merge what are the advantages of composite and what are the advantages of indirect restoration, like the glass ceramic restoration. Because I know that also composite, which I use a lot, has pros and cons. So the pros is that it's very easy to use, is repairable, you can do no prep, you can mold it, okay, you can repolish it easily. Again, it's something that overall is sustainable. But however, is a material that even if it has grown a lot, still today, it's not as stable from an occlusion perspective as ceramic. We know that. We know it in the data. We have seen some lectures today before that were stating this. So hybrid, so it's because in the first upper and lower molars and on the first, and on the canines, upper and lower canines, I will cement onlays, glass ceramic onlays, Emax restorations, okay? This to do what? Because the first molars and the canines are strategical teeth for to manage static occlusion and dynamic occlusion. So that's why I usually place on the first molars and on the canines this kind of materials in order to have a more stable occlusion. On the other teeth, we can perform a molding approach through the index technique. So 20 teeth are going to be molded. This is the anterior part of this case. Also, we had a problem here with a endo-treated tooth, which I then will see later how we manage this. And one of the, in my initial protocol, I will share just a few slides later. I also manage with the Brax tracker in these cases because I want to see overnight the patient, how he behaves, if he's Braxing, and I want to map and read all the paths that for that night that patient is doing. So for me, it is very important also this. We can see here the situation after that he has worn it for one evening. I call the Brax tracker for me is also like a black box recorder, okay, of the planes that we fly in. So it's recording what is happening, what the patient is doing overnight. So we use this device with my technician usually in all the diagnostic data that we collect. And you see how he has posterior interferences. You can see here his anterior interferences. In fact, here on 21 he has a chipping. And here we are managing, I'm skipping due to time, all the provisional part with the mock-ups, as I mentioned in the beginning, and this is the vertical dimension of occlusion that we decide to increase. I use the reference articulator, so we went through an analog, so we did also condylography and all that stuff, and this is the space that we wanted to augment, to increase. And you see it from the technician perspective, and this is the project, okay, the WhatsApp, because this is full analog. Usually the technician is delivering to the clinic the indexes, okay, I have indexes that are full for each sextant, upper and lower, because these I'm going to use them as they are, as you see them here, to do the mock-ups, to do the provisionals, okay, to test the static, the dynamic, the function, the phonetic, and everything, like we do in regular prosto. Then when we have done all the test drive, we are okay, we can start, we place our definitive restoration. So the project was that on the posterior sextants, okay, all 4 posterior sextants, I molded the 2 premolars and the second molar, while on the first molar, it's one of the table legs, one of the glass ceramic restoration that I call them the 4 table legs that stabilize or the occlusion from a static and dynamic perspective. So here again, we see the stabilizers, the flow lines, okay, we'll check them also with the matrices in place, and you see that if no interferences are there, the key is kissing the flow line. Then we have our heated composite. So I use packable composite that is heated in special heaters. I have thousands of these special heaters, but this is the one that I'm using in the last period, and it's very, 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 very good. So I heat up my material, and then after doing adhesion, I will place my heated up composite. I will land. I will check if the key is kissing my flow. I will remove the excess that are in the interproximal area with a probe, and then I will cure. And this is after opening my matrices and after doing the finishing procedures. And then, as you see here, we have done the 2 premolars, the second molar, and then I'm going to cement my glass ceramic only on the first molar, which is one of my table legs, okay? And you see before and after in this situation. So the same procedure also was managed on the lower and on the other side. So we see the free molding with the single index technique, 1, 2, 3, and this is the cementation of the onlay, and we see before and after the free moldings and the onlay. Then we step on the anterior. We need to manage also the anterior area, all opening up the vertical, no prep. So again, the project is from lateral to lateral. Okay, I will do my index technique procedure. So I'm going to do a no prep procedure. and also from lateral to lateral on the upper, the same, while on the 4 canines, I will cement the Emax veneers, and we will see later. Here, before doing all this, I had to do the root canal back again. This is the new root canal. Then I did a walk-in bleaching, home bleaching, and then I did a normal filling there. So this is before and after my bleaching and the let's say the final filling of the root cavity. Okay, and now so I'm going to do my hybrid approach. So I will do my molding approach on the 4 incisors. This is one of them, and then we're going to do the try-in of the occlusal, so incisal and lingual veneers. They're not going to wrap these veneers on the buccal side, but on the lingual side. So I managed this with just a 45 degrees bevel, as you see here, and you see it also here. This is the only prep that I do on the canines, a 45 degrees bevel. All the rest here in the internal part is going to be a no prep. So since it's a no prep, we need to do a procedure to remove the biofilm, then we do the sandblasting down the enamel, and then we will do the bonding procedure, and then we will go and cement the veneers, okay, the glass ceramic veneers. And so this we have from lateral to lateral, we have the molding approach through the index technique, while we have the canines with the glass ceramic. On the upper, same kind of material, also in occlusion, we will have the incisors that we will have in antagonist, composite against composite, while on the canines is going to be glass ceramic against glass ceramic. And so here, this is before, after. Obviously, I have all the steps. I have also many videos on this procedure, but I'm skipping all this due to the fact that we don't have that much time. And this is before, after on the upper. So from lateral to lateral, again, this molding approach through the index technique, no prep situation, while a short bevel and the fine 45 degrees for the canines that has the tip in glass ceramic, and all it's wrapping up also on the buccal side in order, sorry, not on the buccal, on the palatal side, in order to have the new static and then the new dynamic through the canine guidance. We see here some details also concerning not only the shape, the copy paste of the shape, but also the copy paste of the texture, which is also very, very important. Here we have, this was the initial project that we delivered for the test drive, but for the phonetic, we had too much volume here. So I asked the technicians to decrease the volume and to go to this kind of design, and this is what we deliver to the patient. So again, from lateral to lateral, from the internal side, you can see the molding, and this instead are the glass ceramic veneers. And you see, I asked the technician to be short. I don't want to reach the intrasulcus level because I need to place the dam, I need to do my bonding procedure. So there's no need to go inside the periodontal area. This is a short video, just you can see there, I'm sorry about this, some inflammation, because it's just one day after we managed all the restorations and I did the occlusal adjustments, and then I want to just see if I reach my goals, which are a static. In the static occlusion, I want to have contact points with my shim, the shim stock that is 8 microns has to be hold from second molars to the canines, okay? So you see the 8 microns is there in place in the new MI position, and instead it has to shim, okay? I want some overjet instead from lateral to lateral to avoid the constrictive envelope function. Okay, so I want some overjet. And again, instead from canine to the second molar on the right side, I want again my shim stock that is kept in place. Okay, and you see there, then we're going to check my dynamic situation, my canine guidance, or group function if I'm deciding to do group function also eventually until the premolars, not further in the posterior, because I don't, for me, these could be interferences. So, said this was the initial situation of the case, this was the project, and these are the two alginates that I catch after that video that you have seen, after the occlusal adjustments, after the polishing of everything. Because on these two models, I'm going to do two things. I'm going to deliver, the technician is going to deliver to the clinic a night guard to deliver to the patient first, and then I'm going to deliver another Brax checker, okay? A post-op Brax checker. We did before the diagnostic one, and now I'm going to deliver a post-op. He uses it at night, he takes it back to the clinic, and then I want to put it back again, and I'm going to do in the dental chair, when the patient is not lying down but is sitting, I want to do again the movements that we usually do when we do the static, the dynamic, okay, close, go forward, go lateral, go back, eccentric, and all this. So I'm doing all this here, and then this is the initial Brax checker, the one in the diagnostic part, and this is the final one, okay? And you see we have a superimposition of the blue, that is the movements, is the static and the dynamic in the clinic, and the white, that is the static and the dynamic overnight. And you see there are a few things that I don't like. I have on my composite here, he's going in this situation overnight, but no blue here, so he's not going when he's in the dental chair. So I'm going to do with a silicone point, a very, very soft trimming here. And also for me, these on the two molars are two very small interferences. He has also some muscle problems in the beginning, as you see here. So I just wanted to do a very, very soft trimming also here to avoid this kind of situation. So the Brax checker for me, that's why I call it a black box recorder, because it gives me some feedback from this perspective. Here we go to the second and last case I'm sharing with you. And again, the project is the same as you've seen before. So we have done the 4 table legs for the first molars and the canines, and the rest is a molding approach. Also here we had a mix of attrition, of corrosion, and the patient was aware of all this. The two patients are quite young, around 39, 40 years old. And so I went, as I mentioned previously, full digital workflow. You see the initial situation here of the upper, the lower, and these are the posterior sextants, and this is part of the data collection that we are doing with the X-rays, and this was so digital. So these are the scans. I didn't place in this presentation all the scans, but this is the vertical, the initial MI position of the patient. Obviously, we have the upper scan and the lower scan, and then we did, instead of doing the condylography and using the reference articulator like in the previous case that was analog, we are using a jaw tracking system, which is the Mojo in this case, in order to individualize this case, but from a digital perspective, and merge all the information from the Mojo in exocad with all the scans, okay, in order to let the technician deliver the digital WhatsApp. Okay, so we're starting from here, open the vertical, is the WhatsApp, you can see it here, the WhatsApp also, the digital WhatsApp. On the STL files, the technician is delivering also all the flow lines, and we have them also on the 3D printed models, the prototypes, and we have here some samples of these 3D printed keys, okay, transparent keys. Here I'm using one of them. So in the last years we are using this kind of keys, but also we are using still the silicone ones, which are very, very good, but this is a very good option. And this is again the copy-paste approach, one by one, that we are delivering. So again here, one premolar, second premolar, second molar, molding approach, while here, this is one of the table legs with the glass ceramic overlay, onlay, okay? This is the lower sextant. I'm using a conventional key here, a silicone key. I'm transferring my stabilizer, and you see it here, and we are placing the matrix. We can place a Teflon tape if you prefer. It's okay also the Teflon tape. I use also that. It's not so easy to place it in between two molars that have the contact points. However, here I'm doing my adhesion, and then I will use my heated up composite, and then I will cure, I will land with my index. Here I'm sharing with you a mistake, a bubble that I have here, but it's not a big deal. It's not a problem. I can place some more composite there, and I will land again with my index, and then I will cure through the index. And this is the situation. Again, what I want to highlight is when I have a single index, I can clean very well the interproximal, and then when the composite is cured, the finishing is going to be very easy, fast, and predictable. And you see it here from this perspective, and also from this other view. You see here, I was mentioning before the Teflon tape. You can use it. I'm using here a Teflon one side and the matrix on the other side. And I'm going to perform my adhesive system, and then I will also cure and mold the two premolars. Once we have done the posterior sextant, again, I step on the anterior, and I'm going to manage in the same way. So the 4-inch lower and upper incisor are going to be molded through the index technique. No prep, all additive, no prep, while on the 4 canines, I will cement the glass ceramic veneers. Okay, so here I'm doing the try-in of this 3D printed index. Since it's all no prep, I'm just sandblasting. I'm transferring, I'm copy-pasting my stabilizers. So from here to here, I'm just doing the try-in of my index in order to check on the buccal side and on the palatal side with the matrix on place here. The patient wanted to maintain, I didn't mention this, the diastema, okay, that he had. So that was his desire. So you will see at the end, we had, that's why here I didn't place any protection, no Teflon, no matrix, because we had the space, there was a diastema, there was a gap. And so we are checking, however, the correct landing of the index, kissing the stabilizers, okay? So my adhesion protocol, this is the heated up packable composite, and then we are going to, from different perspective, also the palatal, and landing with with my key, okay? And you see it also from the palatal perspective, and I'm curing with 2 curing lights, one from buccally and one from the palatal side. This is after a quick finishing, these 2 images, also from the occlusal view, and this is after removing my flow lines. I usually do the flow lines with a very milky shade, because it's something that then I'm going to remove, as you see here. It's just meant to stabilize my single index, okay? So that's why I usually use a color that is completely different from the color of the tooth. Again, here I'm sharing with you, just to share it, the full index that has more problems in managing the proximal excess. Okay, you see here the other central I managed with a conventional silicone key. However, but it's not easy. I have the frame that has been transferred, copy pasted for sure, but you see the excess, the amount of excess that I have, it's much more than the single one. So I will reach my goal at the end, but it's going to take longer. It's not going to be so easy. And then it's not going to be so predictable to have an interproximal smooth emergency profile, okay? especially when you manage the posterior. The anterior is a bit easier, but the posterior is more difficult. And here I'm going to now cement. These are the three models, the two models, upper and lower, after I've molded the 20 teeth. And now I'm going to cement the 4 table legs, upper and lower, as you see here. So here, just 2 videos that are quite long, but I'm going to, let's say, cut them through the presentation. And the music, yes, is down, so you don't hear it, I hope. And so I'm doing the cementation, but before, since I want to go and do my sandblasting, here I'm placing just matrices, or you can place Teflon to protect your adjacent dentition. You see here the 2 premolars and the second molar that are the ones that I molded previously. And now I'm going to do my adhesive procedure to go and cement my glass ceramic restoration. Okay, so I'm going to rinse the orthophosphoric acid. Then I'm going to place this is a 3-step etch and rinse protocol that I'm managing. It's a very smooth preparation. What I do, it's a circumferential, let's say 45 degrees bevel, so very minimal invasive prep. And then I'm placing my bonding, just checking that no bonding excess is in the interproximal with some floss, thinning the bonding. And then either you use dual cure cement, or very often in these kind of cases, I also use the same composite that I use to mold, or the same composite that we use to do the fillings, heated up, okay? And I place it on the tooth, then I land with my overlay, with my onlay, with glass ceramic onlay. And you see here, the light of the unit is off. And I'm just little by little, don't want to rush. I will decide when the material is going to cure, because it's composite, regular composite, so there's not the chemical part. And then little by little, the assistant is pressing down. You see the composite is flowing out little by little, and I will remove it, okay? And then when I've checked everything, the assistant is keeping down press the restoration. I go with my floss, okay, that has a knot, in order to remove some interproximal composite. You see that it's coming out on the distal, also on the mesial side, the same situation, and checking 360 degrees if everything is clean, if I have other excess material to remove. And then the assistant is keeping down the restoration, and I'm curing with 2 curing lights for 3 minutes, and I'm using as a cooler the suction agent. And then I will do the finishing procedure here with the strips. Let's see if I can go a little bit forward. That is the floss that I'm checking, if it's going smoothly in the interproximal, don't want to have any excess. This is the reciprocal handpiece that I use a lot when I do this kind of restorative, direct and indirect finishing. Has a working side and a non-working side, and it flips 360 degrees around, so it's easy, fast, and safe to do the finishing, whether we're doing direct or indirect. Okay, and then I usually use also, we'll see here, I do a pre-polishing, I check if everything is smooth, no gaps, no let's say overlaps or excess material. And then I use a pre-polishing point for the finishing area. Then I will obviously have to check occlusion later, so I'm not going to touch the occlusal side. And this is the polisher, but just on the buccal and lingual side. Same stuff, cementation of another video, but I just going to cut it so we can finish without any problems. I think everybody's quite tired. And again, but same procedure also for my veneer on the canines. So it's a incisal veneer that wraps also on the lingual side. Okay, so only 45 degrees bevel, as I shared with you on the previous case, that is performed on this area right here, right there. So adhesion, Now I'm going to place the bonding. This is the heated up composite. Let's go. Just want to share when I'm landing with you with the veneer. You see it has the incisal part and the part on the lingual side. Okay, to have a better adhesion. Here now we're going to just little by little, the assistant is pressing down the restoration. The heated up composite will flow out, and then we'll manage everything. Also here we will reach the last part. We're going to do the curing, the finish, and all that stuff. And then you see here the interproximal finishing with this with the reciprocal handpiece, and that's it. Okay, so we see the posterior area. So glass ceramic on the first molar, molding here, and this is the canine that we saw. These are the molar and the canine that we just saw on the video. Okay, this is the anterior before and after. So we have the moldings and we have the canines that are cemented. You can see it here from this side. All this tip is in glass ceramic, and then we have the glass ceramic on the lingual side. This is the functional part, internal part of the upper. So with the molding from lateral to lateral, and you see the canines here with glass, glass ceramic. That was the, sorry, I just stepped back, the frontal view. This was the initial, and this is after. Again, the patient wanted to maintain his diastema. This was his desire. And here it's again on this perspective, lateral view, you can see my Emax restoration, and this is the molding procedure. Again, instead of, since we are on the digital workflow, we're not catching the impressions, we're just the scans of our restorations, okay? This is after finishing everything, polishing everything, doing the occlusal adjustments and all that stuff. We have our new occlusion, okay? And you see it from this perspective in the scans. This is interesting with the digital. You can turn it around, you know better than me, all this stuff. And we see, again, we want a static from second molar to the canines, but I want to have clearance for my overjet in order not to lock my mandible, in order not to have constricted envelope affection. And again, from canine to second molar here. And on these scans, we will perform the post-op Brax checker, and I'm not going to stop here, and the night guard. And we did here a final module here, so the jaw tracking, and you see here, this is before on the right, before the restoration, and this is after. But if you see the movements during the speech, because he is talking here, like I'm doing now, and you can see this was done 3-4 months after the restoration were performed, and you see that here he is not so balanced, so also the muscles, when we are doing, as the previous lecture, when we're doing restorations, also we need to rebalance all the muscles part, the neuromuscular part, and so all this we can see it also here, that this is much more in balance. You can see from this kind of movements compared to the initial side. So also this, the jaw tracking, the digital jaw tracking is giving us this kind of feedbacks. So I'm at the end. I just want to share with you what I think are, for me, some goals, some key points. So we have the posterior support in the static for the TMJ. I think it's crucial that, and to support TMJ and to support also the muscle system. And also for the TMJ and for the muscle system, it's important to deliver again to the patient a good guidance, whether it's a full canine guidance, also a group function guidance, however, avoiding posterior interferences that could lead to problems for the muscles and the TMJs. And do not close intercoronally your case while you're doing your restoration, whether they are direct or indirect. Check also the eminence, so try to work in a individual situation because we have different eminence angled from left to right, and maintain the most two structure when it's possible. So be as much conservative as possible. We have the time, so utilize the least invasive approach because in my thinking, we have the time to be more aggressive in the future. And this balance, this hybrid approach, it's a good balance. It's a compromise, but it's a good balance in my way of thinking in managing this kind of cases from a sustainable perspective, because it's biologically, for sure, is something that has good aesthetics. We have the four table legs that are supporting the occlusion. It's repairable over time. And one day, tomorrow, we can prep and do all indirect eventually. So it's also important to use a repairable technique. I think it's something that for me, it's a good service to deliver to the patient. So here, there's my website. If you want to get in touch with me, you want some more info regarding all this stuff, this is my email. I have my online courses here, where obviously we go deep in all these details. And I just want to thank you very much for the invitation and for the kind attention. And I'm here with you just, I think, to say bye-bye and whatever. And again, it's really a great meeting.
Thank you very much for your great.
Hello, Riccardo. Thanks for your very practical lecture on the rehabilitation of erosive toothwork. Thank you.
Thank you. Thank you very much for the invitation.
Oh, okay. A few words, if I may. Thanks again, Riccardo, for the single molding technique, which is very aesthetical, like reconstitution of the normal morphology of the teeth. Of course, it's based on the acceptance of the patient at the TMJ and vertical dimension and the muscles. This is the whole complex that it's important, and it can be different from one patient to the other after spending a lot of time one by one to reshape the teeth, and still the patient cannot be satisfied, maybe aesthetically, but unfortunately sometimes they have TMJ problem, muscle trismus, and this is something that it should be done very carefully based on the patient's acceptance. But
sure,
it's
also, this kind of approach is something that since you can add, remove, so it's something that is something that if you have muscle problems or TMJ's problems, you can also manage, since it's something that is reversible. It has the table like the ceramic on the molars and on the canines, but the rest is something you can play, adding and removing eventually.
Thank you very much again. And